Hello. Good morning, everybody. It's Holly. I'm going to do my lecture since we have another snow day. First, I wanted to talk to you guys about a couple things. So since the school is closed today, we'll have to make up a time for when you're going to make up my test. Hopefully tomorrow, I have to talk to Carrie. I'll be in Clear Lake with you, depending on if school is closed or not tomorrow. But just watch for that email later on today describing on what we're doing tomorrow, if we will be going for clinical in Clear Lake or if we'll just meet at the college. Otherwise, I know you guys have spring break next week, so we do have to make that quiz up either tomorrow, Thursday, or Friday. So if you come to clinical with me tomorrow, we possibly could have the option of doing it there. Otherwise, if we're at the school tomorrow, we'll do it there. And then Thursday or Friday, possibly maybe you'll have to go to the school and take it. But we'll talk more about that. Like I said, I'll send an email out once I get that clarified with Carrie and Nola. And then I was going through our outline, and I am working on your projects for the end of the year. So I'll hopefully get that information to you after spring break so you guys can start working on that. And then if you guys had the pre-test for chapter 28 and 29 to do, you get 5 points each for that. So if you guys either want to text it to me, otherwise I'll check it when I see you again. If it's tomorrow, then that means bring it to clinical, or if Nola is at the school, then you guys will have to bring that to her and show it to her. And then I'll post the answers as soon as I have confirmation that you guys have got that done. Okay, and then for next week, in case I don't see you, I'm just predicting with the weather, on the pre-test, I'll have that on e-learning. And for the PowerPoints that I'm going over right now, that is on the e-learning site as well. So when you're listening to this, please pull that up. And feel free to email me if you have any other questions about anything. So today we're going to talk about children with gastrointestinal conditions and urinary conditions. So we'll start with chapter 28, the child with gastrointestinal conditions. So basically, when you review the anatomy, you need to understand that the digestive tract takes the food and turns it into fuel for the body. And you guys can read through those couple of slides there. And then there's a picture in your book there that kind of describes the differences between children and adults. You really need to review that just so you can understand the basics of everything that we're going to be talking about. And then remember when we talked about in clinical that the infant's stomach is like the size of a marble when it's born. And then in a couple weeks or a couple days, it goes to ping pong ball size. And at about 1 month, it holds to about 100 cc's of, that's how much it can hold. Then the adult stomach can hold 2,000 to 3,000 cc's. So it's just showing you how much smaller a child or an infant's stomach is. So how do you figure out if there's a dysfunction or something's wrong with the GI tract? We'll do some labs, CBC, ESR. So a CBC would show the white blood cells were elevated if it's a gastritis or, there's an infection somewhere. Also, we could check the hemoglobin to see if they're anemic. And then the ESR means that's a lab we do to see if there's inflammation. And then you can do a CMP to check the electrolytes. LFT, check the liver. Stool samples, x-rays may be done, abdominal, flat plate and upright. chest x-ray, depending on, where the problems are to see. And then they may do barium enemas to help determine what the problem is. Other things they can do are the upper and lower scopes, like the endoscopy or colonoscopy. In your book, it does talk about how they do have a device. It's like a small pill that children can swallow instead of going through the procedure. And then the pill, when they swallow it, it takes pictures as it goes through their body. And then they have a bowel movement, and then the camera is thrown away. So it is kind of interesting. I think I've actually seen that before. And when I was in nursing school, a child I had swallowed the pill, and then the doctor showed us the different pictures it took. But it's kind of a nice option for kids, especially when they can get so like worked up or have a lot of anxiety about a procedure. Also, if someone or a child swallows something, the colonoscopy or the EGD, when they go down their throat, the surgeon can remove something like, say if they swallow something from a game or a game piece or a little Lego or something like that, the surgeon could be able to remove it doing that. So what are some symptoms that the child might have something wrong with their GI tract? Failure to thrive sometimes is what children could be diagnosed with, but really it could be masking something that's going on with the GI system. Itching could mean that there's a liver dysfunction, like chronic itching. And this is if they don't have an allergy to something. Other signs that they may have a disorder with the GI is pain, vomiting, diarrhea, constipation, rectal bleeding, or hematemesis. So what are we going to do as nurses to help them? Provide adequate nutrition, possibly maybe they need to have it's not the Ensure, but for the kids, I think it's called Pediasure, but it's basically the same. It's just for we may have to increase their protein levels. Other things that we can do are the healthy shots or those other things with a sprinkle. You sprinkle it on. It's called, anyways, it's to increase protein. Also, you need to figure out what the pain and discomfort, what is causing that, and what can we do to help them. It could be from medication side effects. So we need to work, with the child and the parents on that to help determine. We'll go over some other disorders because maybe it's possibly they're having a food intolerance. Maybe they are allergic or they can't have certain foods. And then that's why you have them keep a diary or something so you can keep track of what is causing the issues or what's causing the problem. Okay, so the next thing we're going to talk about is congenital disorders. So the first one is esophageal atresia. So basically the trachea and the esophagus aren't formed right. So if you guys look on your PowerPoint there, I did put a picture of the normal, like what the normal trachea and esophagus is supposed to look like. And then these other ones are what happens if they don't form right during, in utero. So it occurs in 1 in every 4,000 births. There's 4 different types. And basically what happens is the GI, the esophagus or the tissue of the GI doesn't separate properly from the trachea or the respiratory tract. So that picture, if you look at that, the first one is when basically it's not connected to the stomach, and then the child would just throw everything back up because it's just a blind pouch. And then the next one is is when the lower esophagus attaches to the trachea. So think about that. It's going to the lung, so that's not good. And then the other one, the esophagus connects to the trachea, lower esophagus ends in a blind pouch. So that's kind of the same like the first one. Anyways, you can read through those. So basically things aren't going where they're supposed to be going. So then on the next slide, you need to distinguish to help determine if the infants are having this issue with their first feeding. The nurse should observe if they're being breastfed or if it's by a bottle. You need to observe that, see how it's going. Are they, able to swallow it? The first sign with the one with the blind pouch may be in utero with the polyhydramnios, which means that the mother has a lot of extra amniotic fluid because the baby isn't swallowing the amniotic fluid to help develop that GI tract, GI system. So that is one of the first signs, can be one of the earliest signs. So in utero, they may know the baby has this problem. At birth, the infant will vomit and choke when the first feeding is introduced. Drooling in a newborn is a really good sign that this is what they have, is because their salivary glands aren't developed, so the baby shouldn't be drooling until they're a couple months old. If the upper esophagus enters the trachea, the first feeding will enter into the trachea and result in coughing, choking, cyanosis, and apnea. So if it's going into their lung, that's not going to be good. They're at higher risk for aspiration pneumonia because that liquid is going into their lungs. And then if the lower end of the esophagus enters the trachea, and the air will enter the stomach each time the infant is taking a breath, which can cause lots of abdominal distension. So how are you going to care for this infant? So if it was diagnosed in utero, then obviously after they're born, they're going to have the surgery as soon as possible. Otherwise, you want to prevent pneumonia, choking, and apnea with the newborn. They may have to have, IV fluids or some other way to get nutrients in, since if they don't have, their esophagus isn't attaching to their stomach. Depending on, they may have to have NG. And then when testing out the first feeding, it should either be the breast milk or the colostrum from the mother, or it should just be clear water. Surgical repair is essential for survival. All right. So basically those infants, hopefully it's diagnosed early on in their infants when they catch that. The next thing we're going to talk about is in perforated anus. It occurs in 1 in 5,000 live births. There's 4 different types. So basically there's 4 different types, just like that other disorder we were talking about, and it's basically the anus doesn't form right, or there may not be an opening there. So that's why it's so important that infants pass their meconium in the first 24 hours before they leave the hospital, until the stool has passed. If it's been diagnosed, the infant is put on NPO and is prepared for surgery. They may have a colostomy placed depending on the severity of their malformation, or I'm trying to think of that. Anyway, so they might have a colostomy placed, and they may have to have, several surgeries depending on the severity. Okay, the next one is pyloric stenosis. So it's the narrowing of the bottom of the stomach. I put a picture in your PowerPoint slide there. So the bottom of the stomach it's supposed to be able to pass, so the food and nutrients and everything can keep going throughout the GI tract, and basically that sphincter is just like this big, and it's supposed to be, like say that big. So it's commonly classified as a congenital anomaly. Usually the symptoms don't start appearing until about 2 to 3 weeks old, till the infant's about a couple weeks old. Usually surgery. It's the most common surgical condition of the GI tract in infancy. It occurs more often in boys. So I want you guys to highlight this or remember this. The most predominant sign is the projectile vomiting, and it occurs immediately after feeding. So basically, like the stomach can't hold that, that pressure builds up, and then that causes them to vomit. And the vomit is usually full of mucus and ingested milk. The infant is constantly hungry and will eat again immediately after vomiting. Dehydration is very high concern with these infants. You may feel an olive-shaped mass in the upper right quadrant of the abdomen. So what are signs and symptoms that an infant is dehydrated? Sunken fat nails, decreased urination, their skin may be looser. So these infants need surgery, and they'll probably have some IV fluids, possibly if the surgeon orders thickened liquids to help, like say just a couple bites of thickened liquids, so that'll just slowly stay in the stomach. Hopefully they'll be able to get some nutrients from that. And then this is usually diagnosed by ultrasound, MRI, or CT, close monitoring of the infant's weight. And remember, with all these disorders that have to have surgery, you're taking care of an infant or a child. Think of them as a surgical patient post-op. How would you care for them? You want to prevent infections, prevent pneumonia. You want to prevent bed sores. We position them every couple hours, have them, you want to prevent all those things in children as well as like we learned about with adults. Monitoring their vitals, you're doing all those same things. So just keep that in the back of your mind when you're learning about these different disorders that need surgical intervention. The next one we're talking about is celiac disease. It affects 1% of the adult population, and it affects 1 in 266 people. So what is celiac disease? Basically, they have a gluten intolerance. So they can't properly digest that. And what has gluten in it? Lots of things, lots of processed things. Wheat, barley, oats, and rye also are things that have gluten in them. So treatment would be to remove the gluten, go to the gluten-free section. There's one in Hy-Vee where you can get everything that's gluten-free. So they need to do that to treat it, and they need to understand that this is like lifelong. They need to have this diet change because even small amounts, can cause damage. So parents need to be educated about that. In your slideshow there's a picture of a child with celiac disease. The abdomen is distended and they have atrophy of the buttocks. So you can take a look at that. So there's 4 different types of the celiac disease. That the National Institute of Health has classified of. You guys can read through those there. Other signs and symptoms of celiac disease is infant may have failure to thrive. Infant is irritable. The stools are large, bulky, and frothy. That's because they can't digest the contents of the gluten. So that's why they are like that. The IgA can be a lab test done to confirm that they have this disorder. Remember, again, the bulky, frothy stools indicates malabsorption. So that means, I think that also when we talked about cystic fibrosis, that's another, issue. So just think about if they're having malabsorption issues and they have those kinds of stool, that's why. Again, there's lots of things that have gluten in it. So parents and children, they may need dietitian to help them figure out what can we have this child eat, what can they eat. And again, it's a lifelong diet restriction. Even the smallest amounts can cause damage to the villi of the intestine. Okay, next we'll talk about Hirschsprung's disease, and that's when there's the colon, the bottom part of the intestines isn't formed right, and it's called the megacolon. And you guys can see that picture there. Absence of nerve cells are usually in that area, causing lack of peristalsis. They can have chronic constipation. This issue can be acute or chronic. It's seen more often in boys and children with Down syndrome. And you guys can look on your slideshow. There's a picture. That's basically what happens. It's not formed right. Another sign that the infants may have this is the newborns fail to pass their meconium within a day or two after being born. Infants may have constipation, ribbon-like stools, abdominal distension. Sometimes younger children, if it's not diagnosed in infancy, younger children, the mother or the parents may bring the child in after they've tried over-the-counter laxatives without them working. If it's left untreated, signs of intestinal obstruction can occur, so they can develop a bowel obstruction. They can also at risk for enterocolitis, inflammation of the bowel. That's a very serious condition. How are we going to diagnose that they have this? They may do a barium enema, rectal biopsy, or measure the pressures in the anal sphincter. So how is this treated, or how is this fixed? They're going to perform surgery depending on the severity of how it is formed, but they'll have to remove the impaired part of the colon and then attach to the intestines. They may have a colostomy for a few months following the surgery until the child is 1 to 18 months of age. A lot of when it was detected, the nursing care depends on how old the child is. In the newborn, we want to detect it as soon as we can. As the children grow, careful attention to a history of constipation and diarrhea is important. You do not want to give tap water enemas to children or infants because this can cause water intoxication and possibly death. So make sure, if the child does have constipation, educate the parents on how you should use the saline enemas, and those are more appropriate only if the doctor has approved of it. All right, the next thing we're going to talk about is intussusception, and that's basically when one part of the bowel slips up into the other part, and it's a serious deal because basically the part of the intestine that it goes up in, that part can strangle that other part. So it could cause death to parts of the intestine. It's often seen at the ileocecal valve. So there's a certain spot in the intestine that it occurs more often than others. That usually has edema. Yeah, so at first it may appear like on an x-ray that there's an obstruction, but then as the other ball starts moving and the peristalsis, it can cause strangulation of that part of the ball, which could lead to that part of the ball bursting, which could cause peritonitis. So it's a medical emergency. The person or the child needs to get in right away. It usually occurs more in boys between 3 months and 6 years. It can it can fix itself, but surgeons don't wait for that to happen. If they know that this is what the child has, they go in there and they fix it. Some other symptoms they may have: a fever of as high as 106. The child may have signs of shock, sweating, weak pulse. Infants may have a severe pain in the abdomen, loud cries, straining efforts, and kicking and drawing of the legs towards the abdomen. Child may vomit green or greenish yellow bile. Bowel movements diminish, little gas is passed. Blood and mucus come out the rectum, but no feces. About 12 hours after the onset of this issue, they call that current jelly stools. So again, how are we going to treat it? They need to have, this is an emergency. They need to have surgery immediately. The doctor diagnoses it by doing an H&P, asking them about, the diarrhea, constipation. They may feel a sausage-shaped mass in the upper abdomen, and they'll do a barium enema to treat it if the surgeon feels that's necessary. But otherwise, they need to have surgery. The next one is Meckel's ditypulum. And basically, during fetal life or while their baby's in utero, the intestine attaches to the yolk sac, and that forms into the vitellar duct, and usually it disappears. But what this issue is, the Meckel's diverticulum, is that yolk sac turns into a pouch, a blind pouch. It's usually near the ileocecal valve and may be connected to the umbilicus by a cord. It's the most common congenital malformation of the GI tract, seen more often in boys. Symptoms can occur at any age, but typically appear by 2 years of age. Painless bleeding from the rectum is one of the signs and symptoms. Bright red or dark red blood or tarry stools, abdominal pain. They're going to do it says x-rays are not helpful, but barium enema or another test is done in diagnosing it. Treatment is surgical removal of that sac or that blind pouch. Again, think of the care of a post-surgical patient after undergoing a surgery, or in this case, like an abdominal surgery. So how are you going to care for them? The next thing we're going to talk about is hernias. It's the protrusion of part of the abdominal contents through the inguinal canal. It can even be in the groin or the umbilicus. So it can come out the belly button there, and there's a picture there for you guys to see that. Babies can be born with this, congenital, or they can be acquired. Some of them may be easily fixed. Otherwise, depending on the severity, they're probably going to have surgery. Emergent surgery is indicated if it's a strangulated hernia. So it's basically the certain part of the bowel or another part is strangling something, then that's an emergency. We need to take care of that as soon as we can. Okay, the next part we're going to talk about is the disorders of the motility and gastroenteritis. So remember, itis is inflammation. So different parts of this, gastritis, or there's a couple other ones. Anyways, just know that that's an infection of the bowel. So disorders of motility with gastroenteritis involves inflammation of the stomach and intestines. Colitis is an inflammation of the colon. Most common causes, it can be from food intolerance. If they have, they're allergic to certain foods, or gluten intolerance, or Crohn's disease, that's another one. So food intolerance, overfeeding, improper formula preparation, or indigestion to high amounts of sorbitol. And sorbitol is that's what's in that's like the fake sugars. And then other reasons why someone may have their bowels are upset is they could have C. diff, and we'll go over that a little bit more in detail a little later on. But C. diff, I did read in your book, and I did have my child tested for this once. But they say that C. diff testing is not really reliable in children under 3 years of age. But anyways, and then know that C. diff is caused from antibiotic use, using too many antibiotics. On question 1, acid-base imbalances likely to develop secondary to diarrhea in a 6-month-old. The answer is number 1, metabolic acidosis. So now we'll go into the gastroenteritis. Treatment is focused on, identifying what the cause was. So like I said, if it was C. diff, then we know that they need to be treated with Flagyl. And then to help prevent C. diff, a child should be on probiotics while they're taking antibiotics. Thing to note, or think about with adults, this is for adults and children, how do you enter that room for somebody that has C. diff? Do you use alcohol to wash your hands? To enter, you have to follow contact precautions. You only can use soap and water to wash your hands, and then things need to be bleached to clean it thoroughly. So basically, anyways, gastroenteritis, we need to figure out the cause, then make sure they're getting adequate intake and output, and then educate the parents and the children about proper hand hygiene, safe food handling and storage, and then all those things to prevent infection. Also, there's a slide there about food allergies, understanding sometimes, like I said with gluten, parents may not understand that certain processed foods have it in there. It doesn't necessarily have to say on the ingredients. It might not say gluten. It'll say milk or something. Anyways, it got different names for it. So just educating them if the child does have a food allergy, that different ingredients or the same ingredient is just maybe called something different. And the dietitian could help the parents with that as well. Okay, next we have is vomiting. So it's usually caused by a virus making them vomit. They're at risk for aspiration pneumonia. That can be a serious complication if they keep vomiting. Sometimes maybe the baby, if it's like a baby, maybe the parent isn't like feeding them like kind of propped up right. Maybe they just need to be educated on how to hold the baby and how you should burp them after they've ate a couple ounces and things like that. Depending on the severity of the vomiting, they may need to come in for some fluids. Parents need to be educated on about giving them small sips. Like if someone is puking and puking and puking, you may have to give the child a small drink of water, like seriously every 5 minutes, like just a little drink to keep them hydrated. Otherwise, if they don't do that, it probably is going to lead to them having to come into the hospital for some IV fluids. And then once the vomiting stops, parents need to be educated, like, don't just give them a full meal. We need to slowly introduce liquids, and then they can advance, like, just clear liquids, and then advance to the brat diet, which is bananas, rice, applesauce, and toast. So they can see how they do. Sometimes it may be a couple days where they just need to stay hydrated until they can start eating again. So if they are in the hospital with us, we're going to be documenting the time, the amount, the color, the consistency of, what they're vomiting, how many times it is, did we give them any Zofran or what did we give them to help? We will be documenting that on the MAR. All right, the next thing we're going to talk about is GERD. So that can happen in children. It happens more often in preterm infants and also more often in children with Down syndrome or cerebral palsy. Those are children with neuromuscular delays. So basically, the lower sphincter in the esophagus is not relaxing, causing the stomach acid to come back up. The symptoms may get better, like, versus a baby once they start walking when they're like 2. Since they're upright more, the symptoms might not be as bad. It may be this is, again, can be mild to severe. In the severe cases, they can vomit, they can lose weight from it, failure to thrive, the infant may be fussy and hungry. So you have to get a good history from the parents on this child. When did the vomiting start? What type of formula are they using? Maybe it could be that they're allergic to a certain formula. What is when the child vomits, what does it look like? Like, again, I said feeding techniques, maybe they just need to be taught more about, how make sure the child is sitting more upright when they're feeding them, make sure they're getting burped. They'll do some testing, a barium swallow, esophageal sphincter pressure, and a pH, like they'll test the pH to see if that's what the problem the child has. So again, prevent overfeeding. Remember, educating the parents on the size of the stomach. I think that is key because a lot of times I think that, adults think that, oh my gosh, the baby only ate this much. Well, that's all the baby needs. It's just hard to get used to. Make sure they're getting burped, proper positioning. And then we can, give them the medications like Zantac, Pepcid, a proton pump inhibitor like Prilosec, and those can be dosed in the child's. I think all those are all available in the liquid form. Also need to educate the parents on the side effects can be drowsiness or restlessness of those things to help with the heartburn. Okay, the next thing we're going to talk about is diarrhea. So most often diarrhea is caused by a virus. It also could be from uncooked foods or not properly prepared foods. And E. coli and salmonella could be the culprit. Also, diarrhea could be caused from C. diff, which how do you get C. diff again? From getting prolonged use of antibiotics and not using probiotics. So again, how do you tell if the infant is dehydrated? What are you looking for in an infant? Or a child as well. Sunken eyeballs, fontanelles are pushed in, skin is dry, tongue and mucous membranes are dry, urinary or urination decreases. So just think about that for test purposes so you can understand that. So again, with most cases, it is a virus, so you do have to let it run its course, and then you slowly introduce the clear liquids and then the brat diet. And if the child tolerates that, then you can slowly advance. Okay, the next thing we're going to talk about is constipation. So basically, constipation is difficult or infrequent defecation when they pass hard or dry stools. A child is considered, so question number 2, do you think a child is considered constipated if he or she does not have a bowel movement at least every 3 days? And that answer is false. Oops. Constipation is defined in your book for children is fewer than 7 bowel movements in a 2-week period. So they can go, a little longer than adults. So to treat this, we're going to increase fiber, increase exercise. We really don't want to give them a laxative or an enema, daily. That could do some damage to their GI tract. So you want to try the increasing the exercise and the fiber. Some formulas, like for infants, have increased iron in them, so they may have to just change the formula. And then, like I said, then give foods that are high in fiber. Okay, next we're going to talk about fluid and electrolyte imbalances. So with the vomiting and diarrhea, those kind of go along with what we're talking about. So if you think about if they constantly just keep puking or, they're having the diarrhea. And also to think that in children and infants, they don't have much to compensate. Their bodies are made up of more water than ours is, so it can affect them more quickly and they can lead to, problems more quickly than it is in adults. So it's really need to pay close attention to, if you have a child that's vomiting or having diarrhea and you're the nurse in the hospital, you need to pay really close attention to them to make sure that they are adequately maintaining, or if it's not by mouth, it's through the IV that they're getting enough electrolytes. And then also it says in infants, the kidneys aren't, 100% up and running. So the kidneys don't know to obtain the water to keep it. So infants are more at risk for dehydration and fluid and electrolyte imbalances. And if you are caring for them, you need to take consideration that we need to have them on a strict INO so we know exactly what they're getting in and out. So again, with dehydration, we're gonna talk about dehydration. So vomiting and diarrhea can cause or lead to dehydration. So types of dehydration, there's 3 different types. It can be isotonic, which means you lose the equal amounts of electrolyte and fluid. Hypotonic, where you're losing all the electrolytes more than the fluid. And then hypertonic, where you're losing more fluid than electrolytes. So once that is determined, which you can determine that through their labs, then that's how you treat the dehydration. So how does this? Yeah, so so normal saline may be what the child is getting through their IV, depending on how they've been diagnosed with dehydration. Infants' kidneys, again, are immature, so they don't conserve water like adults. The nurse needs to make sure the child voids before giving IV potassium, because potassium is lost in almost all degrees of dehydration and is replaced only after normal urine excretion began. When you're rehydrating children, it needs to go slowly. You don't want to do it too rapidly, or you could cause overhydration. And then that's when the body receives more fluid that it can excrete. The child's going to have edema. Then how are we going to treat it? We may, obviously stop the fluids. Or depending on what type of dehydration they have, if they have hypertonic, then you should not give them like tomato juice, because that would increase their salt. And if it's hypotonic, you don't want to give them just plain water, because that can make the issue worse. So early detection of that with edema is crucial. We're going to do daily weights, vital signs, watch their INO. Important for the nurse to monitor their labs. Okay. Next, we're going to talk about is nutrition deficiencies. And then next week in chapter 15 and 16, we'll go over like an overview of nutrition. But I just thought this went along with what we're talking about more than the other things that I could have lectured on. So we're just talking about next is nutritional deficiencies. So first one is failure to thrive. This can either be caused by like a heart defect or some other issue, malabsorption issues, or it could be from not having food available to them, or something affecting their environment that they aren't able to get enough nutrients. And then there's a little picture there of a child who's been malnourished and he's failure to thrive. So usually they can come into the hospital. They've obviously are way underweight. The child can be irritable. They may have vomiting, diarrhea. Depending on how long they've been this skinny, or they haven't. How long has it been since they've had no nutrients? These kinds of things can obviously affect their development in all kinds of ways. They may not be the right height. Their brain may not develop correctly. They may have lots of different issues. So with this, there's a lot of different team members involved. It may have to have a social worker, all kinds of different issues may be involved with this child. So you should be supportive to the mother and whoever is caring for the child. Like I said, emotional starvation can have lots of psychological issues, problems with it, physically, obviously, but then also psychologically. Not getting enough food or nutrients can really affect the child. Okay, the next two things we're going to talk about. Core is a protein deficiency. And then there's a picture there of a child. Basically, they're not getting enough protein. The earliest sign that the child may have this is a streak of white hair on the child, and that involves of what protein does in the body. It gives the pigment of your skin and your hair the color. So if you lack protein, that can be one of the earliest signs. It usually occurs in children 1 to 4 years of age when they've been weaned from the breast. So if they've been getting breast milk up until then, they've been getting the adequate nutrition that they need. And then you guys can look through, there are some signs and symptoms. So treatment is usually pretty simple. They need to get protein. So like you can do those protein powders or other things that are high in protein to get them the protein that they need. Rickets is caused by vitamin D deficiency. Vitamin D works closely with calcium. So if you don't have vitamin D and calcium, your bones may be affected, causing the bow legs and other problems with like your teeth and other bones in your body. So this can be treated with supplements of vitamin D, or depending on the severity, they may have, they need to go in the sunlight. Scurvy means the child is lacking vitamin C. Symptoms include joint pain, bleeding gums, loose teeth. So to fix it, they need to increase their vitamin C, or they need to get some vitamin C from oranges, raw leafy vegetables. They need to get some kind of vitamin C into their diet or a supplement of vitamin C. Question 4, rickets is to vitamin D as scurvies is to what? Vitamin C. Okay, next we're going to talk about is appendicitis. This is the most common reason for emergency abdominal surgeries in childhood. The average age is usually 10 when it's needed. Its cause is usually from fecal matter or a parasite, or it could be from inflammation to the appendix. So it usually starts out the patient has pain in their umbilicus area, and then they'll start vomiting, and then the pain will just be localized to that right lower quadrant. And some tests that surgeons do are the rebounding tenderness, meaning if they press on that right lower abdomen and then they quickly release, the patient is like severe pain, like they're hunching over, like, oh my gosh, it's so bad. That's kind of, or the tenderness called the McBurry's point. That's like, if you have that, like they're pretty sure that you have appendicitis. They can do a CT scan to confirm their diagnosis. Fever is usually not reliable in children for appendicitis. So one thing, we had a child with my other group, we had a child that had appendicitis and she had her appendix out, but she was like 7. So I was thinking, like with adults, how they do the laparoscopically. So there's like 4 holes. The child was so little, the doctor just made a small incision on her right lower abdomen and was able to get it out. So just because they do it laparoscopically for adults, I guess, doesn't mean that they always do that for children. Other tests they can do is an ultrasound to confirm it, abdominal x-ray. It needs to be surgically removed, or it could burst and cause peritonitis, which could be a very serious deal, serious infection. The next thing we're going to talk about is thrush, and that's the same. Children can get that. It's the white patches in the back of their throat. If it's left untreated, the infection can go, down to the GI tract and be a lot more serious infection. So just need to look in the back of the child's lung to see for those white patches. Then it's treated with the antifungal, like the nystatin. It can be dissolvable tabs, or they put it in the child's cheek and then it slowly dissolves. And obviously after they have that, they shouldn't eat for a couple hours, because you want that medicine to go on those patches and kill, do its thing. So that's how that is treated. And then with proper care, it usually goes away in a couple days. The next thing we're going to talk about is worms. So the first one, the pinworms, they're spread from person to person, more common in larger groups when children are like in daycare centers and school areas. So basically it's a worm that gets inside the GI tract and lays eggs. You can do a test, the Scotch tape test, and basically the tape is put on the rectal area and then it's taken off, and then there's eggs. You put it under a microscope, they can see the eggs. So this is treated by anthelamitic medications, or like a Vermox it's called, and they take one single dose of the medication, and then that's supposed to resolve the issue. The next one is roundworm, and you get roundworms because let's say someone defecated in the soil or in the ground, and then the kids go out there and play, and then they eat the soil, and then that's how they get it. So it's usually more common in places like poor areas, or when unsanitary issues, or they're not with disposing of human feces properly, and they're not performing good hygiene. The eggs can live in the soil for weeks, so they may not obviously see that there's feces in there and the child is playing in there, and then that's how that happens. This is treated with a 3-day oral dose of a nitrocyanide. You guys can look that up in your book, but that's how that's treated. Parents need to be highly educated on if their child does have they do get this worms, they need to clean the toilets every day. Everyone in the house will be treated for the issue, and they'll have to clean the toilets every day and make sure everyone is performing good hygiene after using the bathroom. And then just preventing, make sure you're washing your hands before you eat, before you prepare food, and things like that. Next is we're going to talk about just briefly is poison control. So obviously children and infants, more so children, like toddlers, are more interested or curious in medications, or just curious about anything. And they put things in their mouth, and not knowing that it's poisonous and then this is what happens, accidents happen. So if someone came into the ER, or you were a nurse caring for the child, and they're vomiting, you need to pay close attention to the odor of the vomit. What does it smell like? Is it sweet? What do you, and then there's a table in your book that says, if it smells like pears, then it's this poison. Or if it's bitter almond, that could be cyanide. So it's just interesting to look through that. Everyone should always have the poison control number in their phone or posted on their refrigerator, or in the emergency room, like in where I work, we have it posted. So you just call that number, then they tell you directly what to do, how to handle the situation. The activated charcoal and then the ipecac syrup, those are things that you can give to a child to make them vomit. So if it's past like an hour since they ate or consumed the poison, or whatever the bad thing is that they ate, that's not going to help, because it's already, if it's been an hour or you don't know how long it's been, those things are just going to make them vomit, and it's not, they already absorbed some of it. So the damage is already done. And then in your book, if the charcoal and the syrup are given at the same time, they like cancel each other out. So you can't give those both at the same time. You just do one or the other. Like I said, you just call that poison control number, 1-800-222-1222, and you say this is what happened, and then they direct you to what you should do. There's a list there of poisonous plants. And then lots of medications like for adults. So if you think about like somebody that's on diabetes and then a child ate like their glyphosate pill, that could like extremely lower a child's blood sugar, leading to killing them, because if they just took a couple of them versus, an adult might be fine. So just pay close attention to that. And parents, grandparents need to be educated on how to keep those medications locked up, and understand that those children lock things on the medication are not foolproof, because I've seen kids open them. So just because they have that lock doesn't mean that kids can't get into them. Also, not only with children, but also with the elderly, if you're ever giving, or even like someone that has like a mental delay and they have to use the liquid forms of medications, you should be using a syringe to give them that, because that's the most accurate. You can get the most accurate dose by giving it to them like that. And then there's 5 things on this one slide listed that are deadly to children. And one of them that I thought was interesting, which I didn't realize, was Oragel could be deadly to toddlers if given too much. And there's a couple other ones there. So anyways, making sure that all poisons are locked up. Then the next thing we talk about is lead poisoning. So how does a child get lead poisoning? The main thing I think is from paint. And then I know I heard on the news that I think it was in California that these kids at a certain school were getting it through their water. So that's why people, or I don't know, scientists, they test the water. I'm trying to think the right word, but they test the water in all areas. That's why it's important, as a consumer, you should ask for that water report, and you can there's copies available for all people, so you can look at it. But anyways, that's important to note, that you don't want to have your child be drinking lead or eating it. In older houses, I know my doctor always asked, there was like this paper I had to fill out whenever my kids would come in for their checkups. And if your house was older than such and such, then she tested your child for the lead. Like, so it's a blood level they test, and it should be lead, it shouldn't be, they should have no lead in their blood. So in severe cases, too much lead can cause mental retardation or other, it has lots of effects on your brain, and it can have other CNS effects. So beginning signs that you have lead poisoning could be weakness, weight loss, irritability, vomiting, abdominal pain, and constipation. Later signs can be anemia and then the nervous system involvement. And then treatment is obviously reducing lead in the, and you don't want your kids, they had in your book, like kids are eating or chewing on windowsills that have paint on them. So you need to figure out the source and get rid of the lead so they don't do that anymore. Next is foreign bodies. So like I had talked about with the colonoscopies and EGDs, so children can swallow things, and most of the time they're able to pass them just fine. But in the rare case that, if it's bigger or it's obviously affecting their breathing or it's stuck somewhere, then yeah, they have to have the surgeon remove it. But 80% of all ingestion occurs in children between 6 and 3 months of age. And about 80% of those items pass through the GI tract without difficulty. So, it's kind of crazy, but despite that, it can happen and they're fine. And then avoid parents, if that does happen, not to use laxatives. Just maintain their normal diet and they'll pass it naturally. You don't want them to do the laxatives and things like that because that could make it the peristalsis of the bowels will go faster, and then can maybe cause them, like say if it's a Lego, the child could cut into the bowel and cause worse problems. And then I already told you about that. Okay, so remember, at any point, you guys, you can always pause this and take a break. Next part I'm going to talk about is chapter 29, the child with genital urinary conditions. So the urinary system is made up of 2 kidneys, 2 ureters, the bladder, and the urethra. So we're going to go through some issues that can happen with that. So obviously, if a child comes in and they're having issues, they can run some blood tests, ultrasounds to test to see what is going on. A lot of times kids that are getting sexually abused have issues with their urinary or reproductive system because they're getting abused. They may have, urinary frequency, excessive masturbation, severe nightmares. And then you guys can read through that slide. So those are things that could be. Adults who commit sexual abuse, usually, this is question 1. And the answer is no, the child. Next, we're going to talk about different tests they can do. The UA, ultrasound, CT. You guys can read through those different tests they can do to see what's wrong with the bladder. That next slide with terms, like I would make a note card on all those terms because you need to understand them all. So if you get one of those words in your question on the test, you would be able to define what it is. So dysuria is pain while urinating, frequency, urgency, nocturia. Enuresis is uncontrolled voiding after a certain age. Polyuria is too much, and oglaria is not enough. Okay, the first one we're going to talk about is anomalies of the urinary tract, the phimosis, and that's a narrowing of the foreskin, which prevents it from retracting back over the penis. So they need to have a circumcision because it's not, it could be obstructing the urine. So they need to be able to void to live. Then the next one, the epispadias and hyposapedias. That's basically when you guys can look in your, I have a picture on here too, but the urethra is not in the right place. Sorry, the urinary meatus is on, the upper part of the penis, or it's on the below it instead of on the tip. So it's in different places. Surgery is not always needed. And, in mild cases, it's not indicated. It's usually, though, if it is needed, to perform before 18 months of age. And then they usually don't perform the circumcision right away, because the surgeon may use that foreskin when they're having surgery to repair. Question 2, hypospadiosis must be surgically corrected. It must be. That is false. It just depends on where it's at. And then there's a picture there of the different types. It can be either on the top or below. The next one we're going to talk about is extroscopy of the bladder, and that's when the bladder is outside the abdomen. So it's not where it's supposed to be. They also talk about in your book where it's kind of like it's inside out, like it's outside the abdomen. So obviously the urine is going to continually leak. It can cause skin issues. So you need to make sure you're doing great skincare with these children. Usually they're positioned on their back so the urine can drain freely. And then they don't really put a diaper on them. They just put like the diaper underneath them. And ideally they want to have surgery within 48 hours so this can be repaired. And again, so it can be mild to severe. So when I was talking about severe case is when basically the bladder was turned inside out. Okay, the next one is obstructive uropathy. It can be in one or both kidneys. And basically there's a tumor, there's a calculi, there's something, a scar that's causing the obstruction. Hydronephrosis, polycystic kidney, which is a large fluid-filled cyst on the kidney or is in place of a kidney. So they need to have surgery to get that something so the urine can flow. So these things that I just listed are they're blocking the urinary flow. So, if both kidneys are affected, they're going to need a kidney transplant. But if it's only one, then, depending on the severity, they might have to remove the whole thing. Need to understand the bladder of a child can be, the capacity of the bladder of a child can be figured out by doing the age in years plus 2, and that equals the ounces of bladder volume or the capacity of urine that it can hold. Okay, the next thing we're going to talk about is urinary tract infections. More common in girls because their urethra is shorter. It's usually caused by E. coli. And then, depending on how soon they catch it, if, they don't catch it right away, it can lead to the blood, infecting other parts. So usually if the child is under 1, they probably have to be hospitalized to get some IV antimicrobials. Our older children can usually stay at home and treated with oral antibiotics. Parents need to be taught on, making sure children are getting adequate fluids to make sure they're flushing the bladder. Again, preventing, so they don't get another one. Teach parents about avoiding bubble baths, making sure you're wiping the diaper after each time they soil it with a wipe, and make sure that children are washing their hands and parents are washing hands. Their clothes isn't too tight. things like that. Okay, next we're going to talk about is nephrotic syndrome, nephrosis. A number of different types of kidney conditions distinguished by the presence of marked amounts of protein in the urine, edema, and hypoalbuminemia. It's more common in boys, usually seen in children from 2 to 7. It may be related to thymus T-cell dysfunction. Prognosis is good in steroid-responsive patients. So nephrosis, some other signs and symptoms. The first usually is they have edema around their eyes and ankles, and then it becomes generalized. They may have ascites where the abdomen is distended and basically full of fluid. Weight gain, poor appetite, blood pressure is usually normal for kids. Urine will reveal high levels of albumin and low levels of red blood cells. So how are you going to treat nephrosis? We want to minimize the edema and prevent infection. We're going to give them steroids to reduce the inflammation. Pay close attention to the medications you're giving them because you don't want them to have toxicity of those medications. Diuretics have not been effective in using, to prevent the nephrotic edema. Avoid salts because, eating more salt will cause more edema. You want to put kids on INO, but you don't want to, we don't usually restrict their fluid intake unless the edema is massive. So that would be up to the physician. So a thing that you guys should know is minimal urine output for infants is 2 to 3 milliliters per kilogram per hour. For preschool kids, it's 1 to 2 milliliters per kilogram per hour. And then school-age children and adolescents is 0.5 milliliters per kilogram per hour to help you understand that, okay, the kidneys are working, they are producing the urine like they're supposed to. So caring for a child with nephrosis, you're going to be supportive to the parents and child. They aren't going to get any vaccinations at this time. They're going to keep a daily record of the child's weight, urinary proteins, and medications. Positioning them correctly, strict INO and daily weight, and protect them from infection. Again, remember when you're administering steroids, the immune system is depressed and care should be taken to limit exposure to different infections. Nurses should they should always make sure they're performing good hand hygiene and things like that, or don't put them, if they're in the hospital, don't put them down floor with all kinds of influenza. All right. The next we're going to talk about acute glomerulonephritis. Sorry, guys. So this is an infection in the certain part of the kidneys. Usually the first sign is periorbital edema and smoky brown urine. Both kidneys are usually affected. Usually mild cases, people recover within a couple of weeks. Question 3 there. The answer is 3. Nephrosis is to generalized edema as acute glomerulonephritis is to periorbital edema. So with nephrosis, just remember, they did say that early signs are the edema around the eyes, but they're wanting you to know that nephrosis, the first, a sign of it is generalized edema. Next, we're going to talk about Wilms tumor. So that's a tumor, and it's one of the most common malignancies of, basically in childhood. It's abdominal mass usually found by parents or by a physician during a routine health check. Number 4, the most common symptom noted in children with the tumor is an abdominal mass. The tumor, I think, is it's usually by the kidney, and it compresses the kidney tissue usually. It usually causes hypertension until the tumor has been surgically removed. Abdominal palpation must not be performed because if you do that, it can cause the tumor to spread. So when you're doing a head-to-toe assessment, if this was your patient, you wouldn't palpate their abdomen. A sign would be hung above the bed or crib saying no palpation, no abdominal palpation. So treatment, they need to have surgery, and then they're going to have a combination of radiation and chemo. The affected kidney and tumor are removed as soon as possible after, it's been confirmed that that's what they have. You're going to take care of them preoperatively, avoid abdominal exams, and then take care of them postoperatively like you would any surgical patient. The last thing, two more things we're going to talk about is hydrocele, and that's excessive amounts of fluid in the sac that surrounds the testicles. It causes the scrotum to swell. There's a picture in your book on page 680 you guys can look at. Usually it resolves itself, but if it continues beyond 1 year, it needs to be corrected by surgery. The next one is cryptorchidism, and that's basically when the testes fail to descend into the scrotum. It's usually unilateral. It can cause testicular twisting, and that's an emergency. You need to have surgery immediately, or the function of that testy could be lost. And then obviously if it's in the testes of both both of them don't drop, then they could be at risk for not being able to have children of their own later on in life. But unilateral is more common, so it usually happens on one side. These children that have this are more at risk for tumors as a child or as they become an adult because of this. So they need to really be taught proper how to do the testicular self-exams, and then provide them with good psychological and emotional support. Yeah, so just supporting the children well, so they can understand. Okay, and I think that's about it. Watch for that email. Thank you.